Hello, everyone. Professor Brown Kishball here. Let's do some gastroenterology system complaints. We are going to look at nausea and vomiting. So, we are going to understand the common complaint of nausea, vomiting. We're going to apply diagnostic reasoning in the interpretation and understanding common laboratory and imaging used in nausea and vomiting. And we're also going to take a look at the differential diagnoses for nausea and vomiting. Nausea and vomiting are one of the most common complaints that primary care is going to see, as well as it affects quality of life significantly. Nausea and vomiting actually ranked second to upper respiratory infections as the presenting problems in primary care. Gastroenteritis accounts for about 10% of inpatient admissions and more than 1.5 million visits in primary care. So let's take a look at the pathophysiology refresh. So vomiting is that reflex action that's controlled the vomiting center and the chemoreceptor trigger zone. The vomiting center, which is the neurons within the medulla, is stimulated by the input from multiple mechanisms, and this includes the pharyngeal, vagal, and midbrain afferents and the limbic system. The other is related to the chemoreceptor trigger zone, and that is actually located on the floor of the fourth ventricle, and that is directly sensitive to chemical agents that have emogenic potential. It is sensitive to the stimulation of serotonin, dopamine, histamine, cholinergic, adrenergic, and opiate receptors. So, regardless of whatever the stimulation is, once that stimulation occurs, there is a sequence of events that end with vomiting. Three phases are pre ejection, ejection, and post injection. During pre ejection, there's an increase in salivation, there is swallowing, decrease in gastric tone, there may be tachycardia, pallor, and diaphoresis. As you can see, there are those prodromal signs. Pre-ejection is mediated by that acetylcholine. Remember, we are in the peripheral system and the vagus nerve. In the ejection phase, the abdominal muscles and the diaphragm contract. The lower esophagus sphincter relaxes and allows contents to eject through the esophagus and into the mouth. Post injection is the period after expulsion, and that usually results in some relief related to the nausea. So, urgent considerations when we're talking about nausea and vomiting would occur if there are concerns for more serious etiologies. Definitely, if there is a concern for GI obstruction, or there's a neuromuscular issue going on, or even a CNS issue that is creating the nausea and vomiting, and that would be elicited by your patient presentation. So, urgent considerations would include items such as a bowel perforation, gastric outlet obstruction, an acute neurologic event such as stroke, brain abscess, or meningitis, and cardiac issues such as an acute coronary syndrome with unstable angina, and of course, myocardial infarction. So, what are your clinical presentation and clues going to include? Your temporal is always important. So, timing, quality, and any radiation of the symptoms. Are they meal related, as this is going to lead you towards peptic ulcer disease or more situations that include GERD? Anorexia or weight loss would be problematic and pointing you to a potential situation such as cancer. Is there diarrhea present? So, this is going to help you with gastroenteritis because that would point to more maybe an acute gastroenteritis or a food poisoning if there's nausea, vomiting, diarrhea. Are there any neurological? What medications and drugs are important? Really, most drugs are able to cause emesis or are emetogenic. Clues in the presentation. So, what are those signs and symptoms that would be consistent with volume depletion and associated symptomology? You must perform a comprehensive abdominal assessment. The location of pain and tenderness does give you a clue to where we're going to be with possible differential as well as cause. Neurological assessment and then rectal exam should be included for your patient. So let's take a look at some of the top differential diagnoses for nausea and vomiting. And here are some HPI clues as well as exam clues. I put this into a nice little chart for you. This is adapted from Hippocrates. So you can see there the differences as well as if diarrhea is present, and then the location of the expected tenderness or pain, and would be a good thing to print out and memorize. When we look at the diagnostic workup, so based on how your patient presents, it will be conducive to working up the differentials with that. CBC with differential would look for any type of infection. And then CMP, we're going to be looking at electrolytes, LFTs, renal function, leading to our volume depletion and any signs of an acute kidney injury possible. If there's diarrhea, then you would perform some stool cultures and then refer back to the diarrhea lecture for more information based on that. H. pylori, of course, if we have chronic situations or concern that there is an infection present. When applicable, always pull a pregnancy test in those that are of childbearing age. And then we're also looking at some endocrine workup. So A1C, TSH, cortisol, hypercalcemia are all possible differentials related to nausea and vomiting. Imaging in this situation would include plain films, chest and abdomen, as we are looking for any type of obstruction, free air, perforation. Upper GI studies would include a barium or endoscopy. Ultrasound, abdominal kidneys, pelvis, and CT scan, abdomen, pelvis may be included as well. Related to based interventions does go back to what is the cause and then need to see each disease for treatment plans. So please refer to your book or any other online resource for proper treatment specific to the etiology. Basically, you're going to do some type of antiemetic or a prokinetic based on etiology. You can also use some antidepressants that are working on the serotonin. And then severe cases that are refractory may get some gastric electrical stimulation or surgery. All right, that's it for evaluation of nausea and vomiting. See you in our next video.